Hello there, my esteemed viewers and listeners, and welcome back to part 11 of our Pharmacotherapy MCQ series. My name is Dr. Nath Arwa, and I'm a clinical pharmacist by profession and by training. And I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. We seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I would like to urge you to sit back and spare me part of your precious time as I share some tips for high-impact services with you. So in our first case, patient SMK is a 6-year-old girl who was recently diagnosed with mild asthma. So after diagnosis, Budesonide dry powder inhaler, what we call the DPI, with a potency of 90 micrograms per puff, was prescribed for her at a dose of 1 puff twice daily, alongside Salbutamol HFA with a potency of 90 micrograms per inhalation using the metered dose inhaler, and she was advised to inhale 2 puffs when necessary for wheezing and for dyspnea. And those two are prescribed by a pediatric pulmonologist. Now she presents to the clinic with a caregiver for a follow-up appointment for the management of her asthma. So the clinical pharmacist at that clinic evaluates her inhaler technique, and she demonstrates appropriate use. Now, though SMK has been adherent, she has been awakening at night once to twice a week with dyspnea, which she has relieved with her Salbutamol MDI used with a spacer. So which of the following would be the most appropriate adjustment in SMK's therapy now, while maintaining a Salbutamol PRN? Would you change her Budesonide DPI to Fluticasone HFA metered dose inhaler at a dose of 1 puff once daily? Or would you add 10 milligrams of Montelukast orally once a day to her regimen? Or would you change the Budesonide to the 80 milligram Budesonide stroke 80 microgram Budesonide co-formulated with 4.5 formoterol as an MDI at a dose of 2 puffs twice daily? Or would you increase her dose to 2 puffs twice a day while maintaining the same Budesonide DPI? I'll give you 10 seconds to choose the correct answer. I would settle for answer C. Now answer A is incorrect. Since she is inhaling Salbutamol more than once a month for the nighttime awakenings, her asthma, in my opinion, is not well controlled and will require increasing pharmacotherapy. Now her current Budesonide dose to me looks the low dose inhaled corticosteroid therapy in the step 2 of chronic asthma treatment. She should be moved to step 3 of the chronic asthma treatment with the preferred choice of low dose inhaled corticosteroid in combination with a long acting beta agonist, what we call the LABA changing to an alternative ICS isn't necessary or indicated at this particular stage. And Fluticasone HFA at a dose of 110 micrograms daily is considered low dose ICS and would therefore be inappropriate at this stage. Now, initiating montelukast isn't appropriate in the stepwise approach to her asthma management. This can be utilized as an adjunct for the management of allergy-induced asthma, but it hasn't been demonstrated to improve symptom control in patients like this one with persistent mild asthma. So I would not settle for option B. In my opinion, it's wrong. And answer C, in my opinion, is correct. Her asthma isn't well controlled based on her frequent use of salbutamol for nighttime symptoms. Her current budesonide dose is considered low dose inhaled corticosteroid therapy in the step 2 of chronic asthma treatment. She should be switched to step 3 of chronic asthma treatment with the preferred choice of increasing to a medium dose ICS or combination therapy with a low dose ICS plus a LABA. That is recommended for patients within the range of 5 to 11 years of age. So changing to budesonide 80 mics co-formulated with 4.5 of formoterol means that a dose of 2 puffs twice daily would be our best bet. That would be the best option from those 4. And answer D appears incorrect to me. Increasing her budesonide DPI dose to 180 mics twice daily does not provide any added benefit, because the next step in therapy would be the addition of a LABA as part of the stepwise approach to asthma management for children between 5 and 11 years of age. So I would settle for answer C. Let's move to the next question. J.W.G is a 3-year-old girl who was initially started on amoxicillin at a dose of 90 milligrams per kilo of amoxicillin per day orally for her acute otitis media. Now her mother brings her back to the clinic 4 days later with significant earache and significant fever. Things are not improving. Now on examination, both her tympanic membranes are now moderately bulging and they are erythematous according to examination. And the mother reports that she was able to administer the amoxicillin dose to J.W.G for only 3 days due to a bad rash, in her own words, which covered the kid's arms and legs. She stopped treatment after 3 days. So which of the following would be the best next option for J.W.J's treatment? Would you change the amoxicillin to Co-amoxiclav and dose it at 45 milligrams of the amoxicillin component per kilo per day for a week? Or would you change amoxicillin to Ceftriaxone and administer it intramuscularly at a dose of 50 milligrams per kilo once a day for 5 days? Or would you change the amoxicillin to azithromycin and dose it at 10 milligrams per kilo per day orally for 5 days? Or would you change the amoxicillin to cefuroxime and administer it at a dose of 30 milligrams per kilo per day orally in 2 divided doses for a week? So I'll give you 10 seconds to choose the correct answer. So I would settle for answer D. Now A is incorrect. Such a switch would be appropriate in patients who have failed to respond to amoxicillin. However, We know that J.W.G has experienced a hypersensitivity reaction to amoxicillin, and her response cannot be classified as a true treatment failure. She has not failed treatment, she is allergic. She might experience another hypersensitivity reaction if we went ahead and administered Co-amoxiclav, which is very similar to amoxicillin, but it has an addition of a beta-lactamase inhibitor, clavulanic acid. Furthermore, dosing it at 45 milligrams per kilo per day of the amoxicillin component orally for a week is inadequate. That would be an underdose. It would not achieve the optimal drug concentrations necessary to overcome the alteration of the penicillin binding proteins that are associated with resistance to amoxicillin, which causes failure in patients with acute otitis media by, and I'll underline, community-acquired streptococcus pneumonia. So this dose would not be appropriate if the causative agent was community-acquired strep pneumo. Treatment would fail. Now, answer B, in my opinion, is incorrect. Although IM ceftriaxone could be used as an alternative to amoxicillin, 5 days of therapy aren't recommended by the guidelines, especially in initial treatment in patients with acute otitis media in the age band of 2 to 5. We tend to go for longer therapy, up to a week. The appropriate duration in this age group would be 7 days, not 5 days. 5 is recommended for children above 6 who have mild to moderate acute otitis media because of evidence of treatment failure in the younger ones when we use the shorter duration of 5 days. Now, answer C is incorrect. Macrolides such as azithromycin are not recommended for patients with acute otitis media because they have a high likelihood of treatment failure. Now, resistance in the strep pneumo and in H. influenza and in Moraxella catarrhalis, which are the common pathogens implicated in acute otitis media, are high. These 3 microbes have developed high levels of resistance to azithromycin, so I would not settle for it. So answer D, in my opinion, is the correct one. This patient has not failed to respond to the initial treatment with amoxicillin, but she has shown hypersensitivity to the same. So we require an advanced generation cephalosporin such as Ceftriaxone, which provides enhanced stability against the beta-lactamase producing H. influenza, Moraxella catarrhalis, and those are the common culprits in otitis media. And yeah, it's recommended for patients with acute otitis media who are allergic to penicillins, and the duration of 7 days is appropriate in my opinion. So I would settle for switching to Ceftriaxone at a dose of 30 milligrams per kilo per day in 2 divided doses for a week. So K.W.G is an 11-year-old boy with sickle cell disease and SLE nephritis. He receives maintenance immunosuppression with high-dose systemic steroids, and he recently received rituximab. The mother reports to you that he is up to date on his vaccines through the age of 7 years, and she requires information about any vaccines that this boy would receive during today's follow-up clinic appointment, given his medical condition. Now, which of the following statements is correct based on recommendations from the ASIP? Is it A, K.W.G should begin the 2-dose series of meningococcal B vaccine and the 2-dose series of the 23-valent pneumococcal polysaccharide vaccine, the so-called PPSV23, and receive Tdap and can be considered for the HPV vaccine? Or is it B, K.W.G should begin the 3-dose series meningococcal B vaccine and receive a single PCV13 and be considered for HPV? Or is it C, or is it K.W.G should begin with a 2-dose series of meningococcal B vaccine and a single dose of PCV13 and Tdap and can be considered for HPV vaccine? Or is it finally D, K.W.G should receive 1 dose of meningococcal B vaccine, begin the 2-dose series of PCV13 and be considered for HPV? I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. Since this boy hasn't been vaccinated since the age of 7, he is due to receive the Tdap and the meningococcal B vaccines at the age of 11, based on the catch-up vaccine schedule. I'll refer you to the CDC guidelines to read more on the same. He should receive either the 2 or the 3-dose regimen of the meningococcal B vaccine due to his special situation. I would like to refer you to the condition is a sickler, and receipt of high-dose steroids for his SLE and his sickle cell anemia, the reason why I would go that way. He should receive a 2-dose series of the PPSV23 because he would have already received the PCV13 series prior to the 7 years, but he qualifies for additional PPSV23 coverage due to the comorbidities that I've just listed. Now, answer B, in my opinion, is incorrect. He would have received the PCV13 prior to the age of 17, according to most schedules at vaccination centers, but he qualifies for additional coverage with the PPSV23, secondary to his comorbidities. He's a sickler and is on immunosuppression. Now, answer C is incorrect as well because of the same reasons, but he qualifies for additional PPSV23 because of his risks. Now, HPV vaccine would also be indicated given this boy's age, since it is indicated to begin at 11 to 12 years of age, and with consideration for earlier use as young as 9 if a patient is in a high-risk situation. So answer D, in my opinion, is incorrect because he would have already received his PCV prior to the age of 7, and it does not require 2 doses of the same, but he qualifies for PPSV23 secondary to his comorbidities, and he can also receive HPV as early as 9 because of his additional risk. So let's move to the next question. AMO is a 4-year-old girl suffering from seasonal allergies. Now, this was diagnosed after she developed significant rhinorrhea, sneezing, and the pediatrician noticed conjunctival symptoms when she was exposed to tree pollen. She weighs 20 kilos, and the caregiver tells you she has a penicillin allergy. What would be the preferred therapies for this patient's allergy? Remember, the age is 4. Would it be fluticasone furoate nasal spray, 1 puff into each nostril once a day? Would it be loratadine, 5 milligrams orally once a day, oral? Would it be 5 milligrams of montelukast once a day orally? Or would you administer azalastine spray twice daily into each nostril? So I'll give you 10 seconds to choose the correct answer. So I'd settle for option A. In my opinion, A is the correct answer. Intranasal steroids are treatment of choice for patients below the age of 6 with seasonal allergic rhinitis. Now, the furoate form of fluticasone is approved for use in this age bracket. B is incorrect in my opinion. Oral antihistamines are not first-line therapy for seasonal allergic rhinitis. The first-line treatment is intranasal corticosteroid sprays. Answer C is incorrect as well. Montelukast isn't indicated as first-line or alternative therapy for management of seasonal allergic rhinitis. And answer D is wrong. Intranasal azalastine isn't approved by the FDA below the age of 5. So a 4-year-old child unfortunately does not qualify to use it according to the FDA. Let's move to the next question, which says A&R is an 8-year-old girl who presents to your pediatric clinic with her father, to the pediatric pharmacy with her father to refill fluticasone 115 micrograms, co-formulated salbutamol 21 micrograms HFA meter dose inhaler. Her prescribed dose is 1 puff twice daily, and the father, a literate man, recently read about bone health complications from steroid use in asthmatic pediatric patients, and is now concerned about the long-term effects of this medication that you are about to refill for his daughter A&R, especially since A&R's maternal grandmother was recently diagnosed with osteoporosis. Which of the following counseling points listed below should be shared with A&R and the father regarding the inhaled corticosteroids at this time? Would it be, it provides the lowest effective dose of inhaled corticosteroids to control her asthma and to minimize her risks of adverse effects on bone health only if taken with a multivitamin or calcium in conjunction with the vitamin D as part of her overall plan for health maintenance? Or is it B, it provides a high yet effective dose of inhaled corticosteroid to control her asthma, but it increases her risk for adverse effects on bone health unless a dose is decreased and taken with a multivitamin or with calcium in conjunction with the vitamin D as part of our overall health plan? Or is it C, it provides the lowest effective dose of inhaled corticosteroid to control her asthma, but to avoid adverse effects on bone health, she should use the inhaler only as needed for wheezing or dyspnea? Or is it D, it provides the lowest effective dose of inhaled corticosteroid to control her asthma and minimize risks for adverse effects on bone health, and she might consider taking a multivitamin or calcium in conjunction with vitamin D as part of her overall plan for health maintenance? I'll give you 10 seconds to choose the correct answer. So, in my opinion, answer D is the correct answer. Now, A is incorrect because studies haven't definitively shown that supplementation with calcium and vitamin D reduces the risks of adverse effects on bone health from any inhaled corticosteroids used in asthmatic children. Now, answer B is incorrect because Fluticasone 115 micrograms co-formulated with salmeterol 21 micrograms dose at 1 puff BD is considered low dose, not high dose inhaled corticosteroid. And decreasing this dose isn't consistent with guideline recommendations for asthmatic pediatric patients because adverse events from inhaled corticosteroids haven't been observed yet in this patient as we speak today. The father hasn't told you there were any adverse events, and her asthma symptoms appear to be well controlled. So a dose reduction at this stage would probably lead to loss of asthma symptom control. So I would not opt for that option. Answer C is incorrect in my opinion because the asthma treatment guidelines do not support the use of PALS, i.e. PRN. Now, therapy with inhaled corticosteroids for asthma, especially acute asthma, is not done in the PALS mode, and it's not recommended despite literature that supports seasonal use of this treatment modality. So I would not settle for C. Now D, in my opinion, is correct. Studies show that although inhaled corticosteroids can suppress linear growth and increase risks of osteopenia and osteoporosis in children with asthma, the use of the lowest effective dose is the best way to minimize these risks. Now, the use of multivitamins or calcium with vitamin D supplementation, in my opinion, might be considered to optimize bone health, although studies haven't definitively shown that calcium and vitamin D supplementation reduce the risk of adverse effects on bone health from inhaled corticosteroid use in this category of patients. So I would leave it to them to decide. Let's move to the next question, which says CWM is a 3-year-old girl with a recently diagnosed asthma and seasonal allergies, which are currently being managed without prescription medications. She was sound in health 2 days ago when her auntie, who is the guardian, reports, in her own words, hearing whistling sound while she was breathing, and the auntie also reports a fever in the morning and adds that ZWM has a persistent nighttime cough for the last 3 weeks, along with itchy eyes and a runny nose. Now, we are also told that ZWM was brought to the pediatric chest clinic due to respiratory distress. Now, when the pulmonologist examines, she's found to be tachypneic and her respiratory rate is in the 60s. She's not saturating well. She's in the range of 89 to 91 on room air, and 2 salbutamol doses of 2.5 milligrams have been nebulized, followed by a dose of 1 milligram per kilo IV methylprednisolone. She's then placed on oxygen via nasal cannula, and her respiratory symptoms are now improving. Thank God. The pediatric pulmonologist performs a respiratory viral panel whose results turn out negative. The patient stabilizes and the pediatrician prepares to transition her back to home care. So my question to you is, which of the following is the optimal therapeutic plan for patient ZWM? And you bear in mind the follow-up is in 2 weeks' time. Is it discharge her home with Salbutamol HFA MDI with a spacer and a mask at a dose of 2 puffs PRN every 6 hours for wheezing and dyspnea, together with the 5 milligrams of loratadine taken orally once a day? Or would you develop an asthma action plan and discharge her home with the salbutamol nebulizer, nebulized at 2.5 milligrams 4 times daily when wheezing or when she is dyspneic? And in addition to that, beclomethasone 42 mics inhaled intranasally twice daily? Or would you develop an action plan and discharge home with salbutamol HFA MDI with a spacer to be dosed at 2 puffs PRN QID when wheezing or when dyspneic, alongside triamcinolone intranasal spray administered at 55 micrograms once daily? Or finally, would you develop an asthma action plan and discharge her home with the nebulized salbutamol 4 times daily PRN when dyspneic or when wheezing, alongside a 5 milligram dose of loratadine orally once a day and intranasal flunisolide 50 micrograms once daily? I'll give you 10 seconds to choose the correct answer. In my opinion, C is the correct answer. Now, answer A, in my opinion, is incorrect. A key strategy in preventing frequent A and E visits and hospitalizations for acute asthma exacerbations in patients like ZWM here is development of an action plan. Answer B, in my opinion, is incorrect because beclomethasone would be reasonable if this kid was older. Remember, the FDA approves it for patients who are 6 years or older. Now, answer C, in my opinion, is correct. Whenever an asthmatic patient presents for healthcare, they should be provided with an asthma action plan for prevention and management of future exacerbations, and this helps them reduce hospitalizations. Triggers should be addressed as well, which in this case, in my opinion, appears to be the increase in allergic rhinitis symptoms for which she receives no prescription treatment. Now, intranasal corticosteroids are the preferred first-line therapy for seasonal allergic rhinitis in this category of patients because topical management of the symptoms minimizes systemic exposure to corticosteroids. Now, the choice among the intranasal corticosteroids for patients who are 5 and below is limited to triamcinolone or mometasone, not flunisolide. Now, developing an asthma action plan with salbutamol inhaled PRN when wheezing or when dyspneic and triamcinolone dosed at 55 mics intranasally would be the best option, in my opinion, for this patient. Now, answer D would be wrong because of age limit. Flunisolide is not indicated for patients below the age of 6 according to the FDA. Let's move to the next question, which says KSM is a 13-year-old boy with moderate persistent asthma that was previously very well controlled with PRN salbutamol, which was administered when wheezing or when dyspneic. And he was also on Fluticasone 100 mics, co-formulated with the 50 mics of salmeterol, and he was administering 2 puffs twice daily. He was also on Montelukast 10 milligrams orally once a day at bedtime. Now, he recently joined the basketball team at his school and has been waking up at night with dyspnea. Now, he requests for additional information regarding his asthma management. So, what updates to his asthma management plan would you furnish him with in this appointment, in this clinic visit? Would you advise him that because his moderate persistent asthma is no longer well controlled, he should quit playing basketball totally? Or would you review the asthma action plan and adherence with him and add salbutamol 2 puffs prior to the basketball games? Or would you review the asthma action plan and adherence with the patient and increase his Fluticasone dose to 4 puffs BD prior to the basketball season? Or would you review the action plan with him and assess him for his inhaler technique? So I'll give you 10 seconds to make the correct choice. So in my opinion, the correct answer is B. Now, answer A is incorrect. Although patients with mild to moderate persistent asthma can experience occasional limitations in activity, they shouldn't have to restrict all activities if their asthma is properly managed. Now, according to the stepwise approach provided in the 2007, I think, National Asthma Education and Prevention Program Expert Report, which we call the EPR3, every effort should be made to adjust his action plan in the context of well-controlled asthma with a clearly identified trigger. In his case now, trigger is the exercise, the exertion. Now, answer B, in my opinion, is correct. All asthmatic patients should have an action plan, what we call the active asthma action plan, that is used to help them better manage their symptoms and lessen the severity of exacerbations. Now, increased physical activity can be a trigger for asthma symptoms. Remember that. And that can be easily prevented by inhaling short-acting beta agonists like salbutamol prior to the exercise, which would be prior to the basketball game or practice in this boy's case. Now, so that makes answer B correct, and answer C is incorrect. Although reviewing the action plan is important, the 2007 report does not endorse doubling the dose of inhaled corticosteroids for short-term management or prevention of exacerbations, especially like in a case of a basketball game. Answer D is incorrect. Assessment of asthma inhaler technique and review of the action plan are important. They should be provided, but intervention is prudent now, given the increase in nighttime symptoms in a patient who was previously well controlled. So my highly esteemed viewers and listeners, that brings us to the end of part 11 of our series. If this video in any way helped you, I would like to urge you to remember to like it and to subscribe to my YouTube channel if you haven't already subscribed. And I would like to promise you that the best is yet to come. I would like to say I'm very thankful you sacrificed and made time to listen to me and to view this video, and I hope to interact with you in the next video. So I wish you effective and high impact pharmacotherapy service delivery in your line of duty. Thank you.